Okay, so I have clicked record, so we're now recording the session. Okay, so let's move on then now to our first slide to really kick off the process of systematic review searching within an evidence synthesis. So, as I mentioned at the start, this is the third session that we're looking at, and you can see it's number 3 in a diagram here, which is illustrating the different stages of an evidence synthesis or systematic review. So at this stage, we're gathering all the evidence that we need for our systematic review. However, it's helpful to point out just at this time that there are other aspects, other times of the systematic review where you might do a bit of searching as well. So right at the very beginning of the systematic review, you may do a scoping search to try and test out your ideas, to see what the size of the literature is for your systematic review topic, and also to check if anybody else has done this review before. So it's important to remember to do some searching at the very beginning, just to really help you understand the evidence that you're about to find. At this point, sometimes people's questions do change quite a bit, because it may be you find out somebody else has done a review very recently, so yours actually isn't required. Maybe you need to think of a different topic, or sometimes you do a scoping search and you realise there's a huge amount of literature out there, far more than you realised, and you perhaps need to think a little bit more carefully or refine your question a bit more, so it's still answering a really good question, but it's a manageable amount of literature as well. And towards the end of the session, the end of the review, you will do some extra searching, which will sort of add to the main body of evidence that you found. So when you get to the end of the review and you have your set of studies that you want to include in the review, it's very usual that we check through the reference lists of those studies, just to see if they're referring to any other trials or studies which are relevant to your review that maybe our searches haven't picked up when we did them originally. So that's a very common feature, and it's surprising how often that does actually throw up 1 or 2 extra studies. You may also do an update search at the end of your review. It depends how long the review process has taken you. So if from the time that you've done the searches to the time that you're actually writing the review, if that's more than a year, then we would definitely recommend that you do run some update searches, so you're having a look at the results and the new papers that have come out within the last year that might be relevant for you. You don't really want to write up a review which is already at least a year out of date when it's finished. Okay. So this morning, what we're hoping to go through, and this is kind of the order of how we're going to go through searching for systematic reviews, is first of all I'm going to talk about how the searching affects the outcomes of a systematic review. And then I'm going to look at how we identify different databases and sources for a systematic review. And we think that should take us up till around about 10 o'clock, 10 to 10. It'll take around about half an hour or so from now. And then at that point we will have a break, so 10 minutes or so away from the screen. And then after the break, fingers crossed if Natalie's computer is okay, Natalie will be talking about how to design a search strategy using Pico. So that will be the bulk of the session after the break, on quite a detailed look at how search strategies are built and how you can do that from your question. And she'll also have a look at some different software tools that we use when we're doing searches for systematic reviews and managing references. And finally, a really important session on how we record the searches and how we write them up in a systematic review, and how we keep track of all the searches that you do, because you might end up doing quite a lot of different search activities throughout your review. It's important to keep hold of those. Okay, so that's our plan for the morning. If Natalie does have more problems with the computer, then I'm familiar with all the work as well, so I will just keep talking. Okay, so key features of a systematic review search. These are things to kind of remember as we're going through this morning, and this is what we're trying to achieve with the methods that we're using. What we're trying to do is identify all the relevant studies for a systematic review. So we're trying to get as many trials or studies as possible that are relevant to our question, because we want to aggregate the data. We want to get all the data from all those studies together, and then at the analysis stage we're looking for example, averages of effect size. So if we're doing a RCT review, we will be putting all that data together to get the average from all those studies. And the more studies we have from the wider set of institutions or places around the world that have been doing those studies, the more we get, the more likely we are to get a more truer result, a more accurate effect size and average of effect size. So we will try and find all the relevant studies. However, as well as doing that, we need to be mindful that we're trying to find an unbiased set of studies. And I will go into this in a bit more detail in the following slides. But generally the positive trials, the ones that show positive results, are relatively easy to find. So it's quite easy to find a lot of studies which are showing an intervention working well. But it can be harder to find the studies which are showing the same intervention, the same intervention and participants, but maybe it's not in that study performing as well. So those can be harder to find, but we need those as well, so we have an unbiased set. So some of the methods that we use are to try and combat that issue of us just easily finding the positive studies. And the third really important principle, which goes through all of the systematic review methods, is that we have very transparent methods. So people can look at a systematic review and see exactly how all the searches were done, where you've gone to gather your evidence, and make a judgment on whether they think there might be some evidence missing or whether it is an unbiased set of results. And it's quite a usual or a common thing for people to look at systematic reviews and critically appraise on the search quite soon. And they can, that might be one of the first things that they look at to see how they value that systematic review. So it's really important that we write up our methods very clearly, and that we're transparent about that, and that they're reproducible methods. If you read a systematic review that has very scant, very scarce methods on the searches, they haven't really described what they've done, or they've described it in very vague terms, that then starts to ring alarm bells, because you're not really sure how they found the evidence, and then you're wondering if they're not really explaining it fully, maybe they haven't done a very good job. So that's why we're quite keen on being really clear with how we found our evidence. Okay, so I'm going to now talk about different databases and sources and that you could use for systematic reviews. So this part is particularly focused on RCTs, but a lot of this applies, the theories of it apply to any other type of systematic review. And we look at Medline and beyond. We do very often get this question from people, why can't I just search Medline? Medline has, I think, 25 or maybe 30 million records in it. It's huge. It's a huge database of medical journal articles. And a lot of the content of systematic reviews is in Medline, but not all of it. Medline actually only covers about 4,500 journals, and there are a lot more health and medical journals in the world than the ones which are in Medline. So we need to search other databases to cover as many of those other journals as we can. The other issue with Medline is that it only has peer-reviewed journals. It's often quite high impact. And if we just search for those sort of high impact peer review journals and take the data from there, we can get a bias creeping in. So some studies have shown this, that if you don't have any non-peer reviewed articles or reports, the grey literature, the trials which haven't actually been written up in a journal but that you can get the data, if you don't include all of those, then a bias can creep in which gives an overestimate of how effectiveness the intervention is. So if you're just focusing on the peer review journals, you might get changes to the effectiveness size. We think what's maybe going on is that the studies, the trials, which have very positive results for the intervention, which look really good, they're the ones which are interesting to read and are more likely to get into the high impact peer review journals. The studies which of the same intervention, which are just as valid for us, but the studies which maybe show a negative effect, or maybe they just don't have a very exciting result at all, maybe there's just no difference between using the intervention or not, they seem to be the ones that are less likely to be published in a journal, and particularly published in a peer review journal. So that's really why Medline isn't perfect, and we need to go elsewhere to find those sorts of studies. Another issue with Medline is the subject coverage. It covers medicine and health in general very well, but other databases cover some particular aspects much better. So Embase, which is a European database, it's very large as well, but it covers drugs information better than Medline. It has more pharmaceutical journals. So if your systematic review is looking at an intervention which is some kind of drug therapy, then you'd really want to use Embase if you've got access to that. Similarly, PsycInfo is a mental health database, and that has psychiatry and psychology journals which you just wouldn't find in Medline. And we use CINAHL for nursing. So there's a whole range of different databases that have a subject specialism or just cover a different area better than Medline. There are some sort of language and geographical factors that come into play as well with the different databases. So Medline is North American based, and it will have a North American bias. It does have international coverage, but it perhaps doesn't cover the European literature and rest of the world literature as well as it's covering the US literature. Embase is a European database, and that covers the European literature and the UK literature better than other databases. And I will show you some other databases as we go through, which may be covering different regions. Language is also can be an issue in systematic reviews. Depends a little bit on your topic. As to where those trials will be, or those studies. That's really what we need to be thinking about. Is, if you're looking at a tropical disease, then which may be very prevalent in a particular region, then maybe we need to be looking at the databases that cover that region, but also ones which are in the languages which are used in that region. The Medline and Embase are predominantly English language, but they do have some international coverage. Their abstracts are in English, so you can read those there. But it may be, I've done work where we've searched Chinese databases in Chinese to find Chinese medicine, and we've found studies there that we wouldn't find in other databases. So language is important to think about. I generally advise against limiting your searches to English language. Find all the studies that you can. If there are some that are not in English language, or they're in a language that you are not able to translate, there are methods we can use to deal with that. You can ask volunteers to just translate the data that you need for your review. You could use software, translating software, or you can pay people to translate, or you can just park those studies in your review and not actually look at them any further than the title and the abstract. But you can say that you found them and that you're aware of them. So it just shows you're aware of the whole evidence, and it signposts anybody reading the review that actually there is potentially some useful studies in a different language. So if people want to take the review forward and maybe update it, then they're aware that they need to look for some resources to deal with the language issues. Okay, so if we can't just use RCTs, sorry, if we can't just use Medline, where do we find all of the RCTs? We can look in Medline, Embase and the Cochrane Library for starters if you have a subscription to Embase. These are the 3 databases which have been sort of proven to have the majority of trials that the systematic reviews have been using. Excuse me. So there has been some research done over the years to see where are the trials held, which databases are essential. It obviously depends on your topic. So if you're doing a mental health trial, I would really urge you to try and look in mental health databases and so on. But as a rule of thumb, if you can search Medline, Embase and the Cochrane Library for trials, then you should be capturing the bulk of those available. However, if you're searching for other study types, then we don't have that research to say exactly which databases you should be searching. So you have to use your sort of common sense and maybe trial some out, test different databases to see if they have relevant content. So they're the 3 key ones, but also the trials registers have proven to be really useful as well. So the trials registers are where people are registering their trials or their research, and what we've found, what the researchers found, is that there are trials that you can find on these registers, which are freely available, that you won't find in the journal databases like Medline and Embase. They've not actually been written up as a journal, or if they have, they just haven't got into those databases. So you find unique trials there. But also it's been found that there's trials that you find through the journal databases, through Medline and Embase, that you don't find in the trial registers. So we need to search both. It's a bit frustrating, but wherever you look, you do find more trials. So those are key sources, and I'm going to look a bit more in depth at those, and after the break Natalie will be looking at how we actually search some of those sources as well. Other search activities which people do to find trials are looking through reference lists of relevant studies. So I mentioned that before, that we would at the end of the review, you look at your included studies, the final few studies that actually make it into your review, and check the references for any relevant studies. Also, another really useful way of finding some more trials is to contact the study authors themselves, or maybe experts in the field, organisations who are involved in this kind of research. So if you can go direct to those people and ask if they have any trials which are not available in journals, any data that they can share with you, that can be a valuable way of finding more trials and studies. Another method people use is scanning unpublished literature. So conference abstracts are a really good example of this. If there's 1 or 2 conferences in your area which you think might have studies that would answer your review question, then it's worth scanning through those. Sometimes they might be in the conference database, like the Web of Science, but they're not always there. So you could go to the conference website, download the proceedings as a PDF, and scan through that to see if there's any relevant studies and trials there. It varies a lot between different topics, but for some, for example, for cancer trials, I think only about 50% of the conference abstracts of cancer trials actually make it into a journal and could be found in, say, Medline and Embase. So there's a huge number of trials which are done. They maybe get to a conference, but that they might not be written up much further than that, and we need to try and track them down. And finally, another couple of slightly different search activities, ways people find trials. One is to do a bit of citation searching, and you would use something like Google Scholar or Web of Science to do this. What you do is you search for a key study that you're aware of. So maybe something that was written, say, 5 years ago in 2015, a landmark trial or study, and then you click on a button which often says something like cited by, and the database will then show you all the records of papers that have been written since 2015 which have cited that original 2015 paper. So all the more recent studies that have been building on that work. And that's another way of just exploring the area of research and seeing if there's any new studies related to the one that you've been interested in. And some projects launch a website for their project and for their systematic review, and ask people to send in any studies that they think would be useful or relevant. So that's another way, is to try and canvass your colleagues and perhaps set up a central area for people to send studies and data to. Okay, so I wanted to just share with you a few of the databases that we've been using for LMIC systematic reviews. So these are freely available. PubMed is, I'm sure you're all familiar with this, it's the free version of Medline. So that's obviously a key resource. But also we use the regional databases within the Global Index Medicus. Global Index Medicus is a sort of an overarching database within the World Health Organization website. You can get to it through there or using this link that I've posted up here. And it covers databases from different regions. So we have the African Index Medicus, Western Pacific region, Latin American, Caribbean, and so on. And you can either search those individually or you can search all of them together. So it depends really on, obviously, on your question, on the area that you're interested in, as to which of those regions you think will be useful with studies for you. And I've also put in the Cochrane Library, really because it's a really good source of trials. The Cochrane Central database is made from lots of searches of other databases to find trials. So it's kind of scooping up trials from Medline, but also Embase and PsycInfo and CINAHL, and hand search results. So there are, you know, it is, if you're doing a review of trials, it's a definite one to look at. It should be, I'm hoping it'll be free to all of you on the call. Countries have to subscribe to the Cochrane Library, but there are lots of deals that have happened between different countries and LMIC regions, so I would anticipate that you all have access to that. As well as the free databases, there are subscription ones. And everything that I'm showing you here is really just at the tip of the iceberg. They're just selected. So we have big lists of lots of different free databases and also subscription ones. But this is just to give you a flavour of the kind of things that are useful. So as I mentioned a little bit earlier, Embase is a really good database, but it's because it has a slightly different coverage to Medline. We get a lot of overlap when we search the different databases, but they always have something unique as well. There is a subscription database called Global Health available to us via Ovid, so we've found that useful for our low middle income country reviews. PsycInfo for mental health, CINAHL for nursing and allied health. And also we sometimes use the large multidisciplinary databases. So we've got Scopus and Web of Science here at Leeds that we search, and they cover, you know, a huge range of science, but also social science and humanities topics. So it's been helpful when we've done systematic reviews of IT, for example. We've looked at IT networks in hospitals, and using those multidisciplinary databases, we can get to the computer science journals and literature, which also talk about IT in hospitals, and environmental science systematic reviews, and using arts in sort of art therapies in health. So, you know, they come into their own really when we have those sort of different broader research topics. Okay, I wanted to show you this. It's a very recent article. It was literally just came out a few weeks ago, and every so often we do see similar articles like this, which really underline the importance of why we need to search beyond those databases and look for the unpublished or grey literature. Grey literature is really anything which isn't commercially produced. So that's anything which is not a journal article, not a book chapter, not a book. So things like reports, conference abstracts, dissertations. There are lots of ways where trials and studies are written up as research reports, although data is collected together in a dissertation, but it's not actually, doesn't actually become a journal article, and that's where those are the papers that we need to find. Anyway, this very recent article looked at it was a systematic review of the effectiveness of analgesic medicine for low back pain. And what they did was they looked at what happened if they took out the data that they'd found in the unpublished literature, in the grey literature. So the review to begin with had both published literature and unpublished literature. And the meta-analysis had been done on those results. Once they took out the unpublished literature of from the meta-analysis, the results of the whole review changed, and the estimate of effectiveness became higher. So when the unpublished literature is also added into the meta-analysis, the actual estimate of effectiveness is lower. And this has been repeated in a few different areas. So it's really interesting, and it does underline why we should really search for these sort of studies. There has been conflicting research as well that has shown that in some areas, in some topics, the use of grey literature has had very little impact on the estimates of effectiveness. So we haven't got a sort of a great rule that says yes, you should always search the grey literature, or, you know, in these particular healthcare conditions, grey literature is important. Unfortunately, we haven't got that information yet. I would try and always search the grey literature, unless there may be a reason why you think, well, actually these sort of studies are just never in the grey literature. That would be the only sort of instance where I think you could probably not search the grey literature. Okay, so here are a few examples of where we find grey literature. For trials, the clinical trials registers are a great source of those. So in many countries, there is some legislation that some kind of trials need to be registered, and the details go on. It's not consistent across the world as to what trials have to go on a trials register. So we know that we'll only get we won't get all trials by looking at trials registers, but we will get some there that we don't find elsewhere. Clinicaltrials.gov is a US site, but it does have international trials on there as well, so that's a really useful one to search. These top two are the ones which the Cochrane collaboration recommend that you search at least: the Clinical Trials Government one, and the WHO Trials Registry Platform Portal. Unfortunately, at the moment, due to COVID, the WHO portal has been paused. We can't search it. They haven't actually got the capacity to maintain that with everything going on. It normally functions as a large database that pulls in all the trials from different countries. So there's an India trial register, a Dutch trial register, a Korean one, and they all go into one big pot in this portal. But unfortunately, we can't access it at the moment. We can still search those individual registers, and I'm just hoping, fingers crossed, that at some point in the future, you know, this will come back and we can search it again. Okay, other places. I mean, it's really thinking quite laterally sometimes about, you know, who might be doing these studies and where might they be if they haven't gone into a journal. So there's open access journals that are freely available, and we have a link here for the directory of open access journals. So you might find some non-peer-reviewed and peer-reviewed journals in there that you don't find through Medline and Embase. There's also lots of repositories, so different universities and institutions have their own repositories where they put their research reports. MedArchive preprint server has become quite famous recently with COVID, in that people are putting their research, their COVID research, there as soon as it's done, while they're going through the process of trying to get a journal article published, which can take months or even years to do. So it's great that people are putting their research onto these servers like medArchive for the moment. Obviously, at this stage, it hasn't been peer reviewed, but searching these places alerts you to where the trials are, where they've been done, and you can, contact them directly for data. Or you use those within your systematic review, but you can acknowledge that it might not have been, that it's at the stage of being on a preprint server. Also, we have institutions, sort of worldwide institutions like the World Bank, who have repositories. So some of these large institutions, charities, are doing their own research, like the World Bank and the WHO, and so on. And they may not be writing all those research results up into journal articles. They have repositories where you can see their research. So the Open Knowledge Repository at the World Bank can be useful. And here's an example at the bottom of a very specific, one country, Bangladesh has an archive where it's keeping its research. So there can be very specific archives and repositories which could be really useful for you. So think about the country, maybe think about the topic, because it might be topic specific. There's an economics repository that people put unpublished journals articles in. So yeah, and I've given you a few here. What I would suggest at this point is, when you come to choosing which databases you want to use, is talk to your librarians, or if you have information specialists to hand as well. So, information specialists and librarians in your institutions, even if they've not done systematic reviews before, will be very aware of different sources of information and which sources will be able to help you, which sources their library subscribes to, or places that they can get hold of information that you might not actually be aware of. So it's really important and really useful to make the best use of their expertise in knowing where the knowledge is that might be useful for you, and how you can access that as easily as possible. Okay, so we've come to really the end of my bit about talking about the different sources of databases of data and choosing those databases, and also why it's important to do that for reducing the bias that we might get in the review. I've got a little quiz here. I know we've had people joining sort of throughout the last half hour or so. Welcome everyone. What what we'll do is there's only 3 questions. If we go through them, and I'll talk through the answers, which might be a useful refresher as well for people who are joining a little bit late. Natalie, I don't know how your computing situation is at the moment, but are you able to launch a poll?
No, I don't have any poll icons on my screen at all. I'm sorry, Judy. Are you able to do it from your end?
I can, yes. Okay.
Yep. Sorry about that.
But Natalie, presumably you can you see the chat? Are you?
Yes, I can see the chat.
So if people do have questions as well, please start to put those in. But let's launch the first poll of these questions. So, which of these are key sources of RCTs in health? So you can pick multiple ones of these. We'll leave the poll open for sort of 30 seconds to a minute. So if you're looking for RCTs, which of these databases should we look at? There's the Cochrane database, there's Embase, and Medline, Open Knowledge Repository, and International Clinical Trials Registry platform. Hopefully you've got a poll box on the screen that you can start to vote with. If you haven't, just please pop your answer in the chat. It's something to do with some PC settings. A few people may not be able to see the poll. So
including me.
Oh, okay. So we've had some responses. I'll leave it open just a few more minutes if anybody else wants to vote and put their responses in. We'll have 5 more seconds. 5, 4, 3, 2, 1. Okay, so I've ended the poll and hopefully you can see the poll results. Are you able to see that, Natalie? Just curious.
No, I can't see anything, Judy.
Okay, well, I'll go through them and there may be other people who can't see as well. So, yeah, 83% thought that Central was a key source of RCTs, which is correct. 50% thought Embase was, 83% thought Medline was, 0% voted for the World Bank Open Knowledge Repository, and 50% voted for the World Health Organization Clinical Trials Registry platform. Okay, so that's correct, basically. Thanks very much, everybody. The Open Knowledge Repository isn't, I wouldn't class it as a key source of randomized controlled trials. It will certainly be useful for some types of searches that you're doing, for some types of reviews. If you're looking at low and middle income countries, it could be useful. It's worth just having a test to see if it looks like it might be helpful. But yeah, the main ones are the Cochrane, Central, Embase and Medline. They have the majority of the results, and the trials registries are also been proved to be really helpful as well. That's great. Actually, sorry, I think I've just missed a button here. If I press share results, can you now all see those results? Can you see those results now, Natalie?
No.
Oh, okay. Sorry. Well, hopefully other people can see them because it is saying share results. So yeah, it's the first time we're doing these polls. So bear with us. Okay. If I go to stop sharing results, and really now we've got what time is it now? It's 5 to 10. So we've got a few minutes now before we can stop for a break. If people have got any questions about what we've been talking about this morning, or things that have come up in the quiz, please just pop them in the chat, and we'll just leave that running a little while to see if anything comes through.
I haven't seen anything yet. Doesn't mean there's nothing there though, the way my computer is today.
Yeah, no, I haven't. There aren't any questions as well. We have about 18 people in the meeting now.
Yes.
Okay, it's all looking pretty quiet. So how about we take our pause as we planned at this point, have 10 minutes away from the screen, and yes, please have a stretch, and give yourself a bit of a break before we come back for the next hour.
Judy, we've got a question before we all go from Mary, sort of asking that when you do the scoping search and don't find any results, should you still proceed?
Okay, yeah, that's a good question. So if you do a scoping search for your question and there doesn't appear to be any evidence or any trials on your topic, it depends really why you're doing the review. So you can have an empty review. You can have a review where there are no included studies, and the bottom line, your final result is that there are no studies in this. It is an important question, therefore we need to have some studies done in this. There's a research recommendation, and certainly in the Cochrane Library there are some reviews like that where it's been seen as a really important question to ask, and people have searched quite widely to see if they can find any studies, but in the end none have been found. If you're doing this for maybe a student project, if you're sort of learning how to do a review, then and part of you doing the review is to understand the methods, then really I think you probably need to look for a different question, because you need the practice of how you screen and data extract and analyze those results. So I think it depends a little bit on the purpose of your review, as to whether you should then abandon everything and look for a different question, or whether actually it won't take very long to do that empty review. You do your search and you'd screen, and then you'd just kind of come up with there's nothing that's relevant here. So we have a strong recommendation that this is a big gap in the evidence. Okay.
Yep. We don't seem to have any more questions at the moment.
Great. Okay, well, it's 2 minutes to 10 UK time. So if we meet up at 10, maybe 10 past the hour, 10 past 10, and either Natalie or myself will start the next session then. Okay, thank you everyone. Judy kept breaking up, so I think we've got a really bad connection there.
on. I hope not. But I'm just about to do some recording, so.
Hello everybody, we're nearly ready to start the second session now. We'll just be about another minute while we get set up. So thank you for your patience and I hope you've had a nice break.
Right, I'm going to hang up now. Okay, welcome back everybody. I'm going to take over from Judy to talk about building a search strategy today. Apologies if I break up. I've been having lots of internet connections this morning, so hopefully Judy will let me know if anyone's having trouble hearing me. So, first of all, I'm going to talk about how we design a search strategy using our PICO. In our previous seminar, Tony talked through quite thoroughly about how we use PICO to formulate a research question. And we also use the PICO formula as well to help us build a search strategy from scratch. I'm going to use this example question about looking at smoking cessation interventions to find out which are most effective in reducing smoking amongst people with schizophrenia. So what we do when we start to sort of build our search strategy and design our concepts, we use our PICO tool. So starting off, we're sort of looking at our P component, our participants, and what we're going to be looking for when we search is for people with schizophrenia. Then we're going to be looking at smoking cessation interventions. And for my particular question, I'm not interested in any one. Did anybody hear that? Okay.
Yeah, yes, Natalie, I don't know, I heard it, you were quite faint.
Yes, I forgot to put my headphones on.
Oh.
So apologies everyone, technical glitches. Okay.
You're clearer now, thank you.
I only just realized. So what I'm going to be looking for when I'm developing my search strategy is I'm going to divide it into search concepts using our PICO tool. So first of all, I will use the P and I will look for people with schizophrenia. So I'll be thinking about words and terms and designing a concept with schizophrenia. Then I'm interested in interventions, what sort of interventions are available for smoking cessation. Now I could be interested in particular ones like vaping or nicotine patches, but for this particular question, I'm interested in all of them. My comparators could be anything. It could be comparing one smoking cessation tool with another, or it might be standard care, or it might be placebos. Then my particular outcomes of interest are looking at a reduction or ceasing smoking for at least 6 months in our population. And I'm only interested in looking at randomized controlled trials. So when we design a search strategy, we don't necessarily use all 5 of our PICO concepts. There's a couple of reasons why we do this. If we actually do one huge search using all 5 concepts, it can get very, very large and very, very complex. And it's also quite complicated if you're going to translate into different databases and look for clinical trials. So what we tend to do is we tend to choose usually somewhere between 2 and 4, generally around about 3 of the key search concepts. And often they can be either the easiest ones to search for or the ones that are going to be the most specific. So in this particular example, I'm only going to search for my participants. So I'm going to do a search for the concept of schizophrenia. I'm going to look at smoking cessation interventions. I'm not interested in any single comparator, so I don't need to search for that concept. I'm also not going to search for my outcomes either. One of the reasons I'm doing this is because I'm interested in a reduction in smoking for 6 months, but that's quite a complex thing to search for because it's a minimum of 6 months. So I'm also interested in 9 months, 12 months, a year. So that's where our screening comes in. So sometimes we can use screening as a tool rather than using a search concept. The other search concept I'll be looking for is randomized controlled trials. Now, when we start to build a search strategy, what we do is we need to think of lots of alternative terms, and we need to do it one concept at a time. So what we want to do is build a great big set of words and terms and topics. So the first thing I'm going to do is think about my schizophrenia search. So how will different authors talk about people have schizophrenia, sort of talk about the disease itself, schizophrenia. The author might be writing about schizophrenic patients, schizoaffective disorder. Perhaps they're going to talk about people with paranoid schizophrenia, psychosis, psychoses, delusions, hallucinations. There's all sorts of different ways that we can sort of talk about the concept of schizophrenia when an author is writing a paper. So what we need to do is think about how is the author going to write it down. The next thing, once I've sort of gathered together all of these terms, is I want to think of my second concept, which is smoking cessation. Now, again, there's lots and lots of different smoking cessations, and there may also be tools on the market that we're not aware of either. So what I would do, first of all, is sort of gather together the ones I know. So I know about nicotine patches and nicotine gum. I know vaping's important. I know that we can use e-cigarettes. But authors might also talk about things like an intervention that causes smoking cessation. They might mention about stopping smoking, reducing smoking. It could be cigarettes they're interested in, or tobacco, or even marijuana. So it's very much like being a detective. You sit there, you find a few papers, you read the abstracts, you look at what the authors are saying, and then you keep adding that into your search strategy in an iterative process. And finally, my search concept that I'll be using and building from will be my randomized controlled trials concept. And again, there's lots of different ways we can think about searching for randomized controlled trials. We have the US and the UK spellings, randomized with a Z and with an S. Interventions could be randomly assigned. It might just be written as a trial or as an RCT. Generally, if it's an RCT, there may be a placebo involved. It could just be a controlled clinical trial. We'd like to sort of see double blinding. So again, I've got to sit there and think, what are all the different ways that we can look for RCTs when I'm searching for a study? Now, there's ways that can help us do this because there's no way we can sort of think of every possible way an author might write something down. So one of the tools we use when we're doing literature searching is truncation. So we use the star or the asterisk symbol. And this is a great little tool. So instead of so for example, if I was interested in bike helmets for cycling, there's lots of different ways we can look at cycling. There's bicycling, there's cyclists. So by using the asterisk tool, I don't have to think of all the variations that an author might use. And this is great, but we do also have to be aware that sometimes you can have your false friends. So for example, with my example of cyclist, if I type in CYCL, cycle, I will find my cyclist along the branches of the tree, a cycle, cycling, but I'm also going to find words like cyclone and cyclophosphamide. So again, be prepared if you are using truncation that you may not necessarily find what you want all the time. Another tool that can help us think of all the different alternatives an author might use when they're sort of talking about the same phrases that we're thinking of is subject headings. The most commonly known of these is MESH, which is used in Medline and PubMed. And all that is it's a controlled vocabulary used by the database where they use standard words and phrases to describe the reference content. So regardless of which database provider, so Judy mentioned earlier that PubMed is the free version of Medline. So if we are getting Medline, whether it's from PubMed, whether it's from the platform Ovid, whether it's provided by Web of Science or by EBSCO, every single time we use the Medline database, the mesh headings will remain the same. So using these mesh headings, it means we don't have to think about what words the authors have used. So it will help us do that. It's because authors use different phrases, but also things change over time. So for example, heart attack will be given the mesh heading myocardial infarction because that's the clinical term to use. But if you're not familiar with the subject area, you may not necessarily know that. Mesh headings also help us because sometimes authors don't actually write our keywords in the title or the abstract, even though the content of the article is about that. One of the other good things about using subject headings too is they're controlled and they're consistent. So when we're building a comprehensive search strategy, what we need to do is use a combination of our text word terms and our mesh headings. Now, the reason we use both is it's not always 100% accurate or reliable who the indexes are and whether or not they give you a correct mesh heading. Okay, so how do we find our mesh headings? Well, sometimes databases have tools to help you. There are mesh browsers online, and one of the key things that Judy and I do when we're looking for mesh headings is we look at relevant papers and find out what content has been coded by the indexes and what mesh headings have been given. It's not intuitive, and I would really, really recommend that when you are looking for mesh headings, talk to your librarian, use guides online. We've got a nice link here to help from Leeds University Library. One thing we find as well is when people are doing a database search is, and particularly in the Ovid platform, they want to try and search multiple databases at once. I really strongly recommend you don't do this. So it will work for your keywords to look for the same things, but different databases use different subject headings. So if you try and you search multiple databases at once, you're automatically cutting out a large proportion of your potentially relevant articles. Okay, oh, I beg your pardon, I've gone up instead of down. Now, as we start to build our search strategy, we use something called Boolean logic to combine our search concepts. So we have three concepts in our search. We're looking for smoking cessation and smoking cessation tools. We're looking for people with schizophrenia, and we're looking for randomized controlled trials. So the first thing that we do is we build up a nice big set of searches for our initial concept. So for example, in our smoking concept, I'm interested in all of the papers to do with smoking, all of the papers to do with cigarettes, and all of the papers to do with tobacco. A nice easy way to remember it is or is more. So whenever you use or in a literature search, you know you're going to get more and more references. So we're trying to build up a nice, great big set of references to do with each of our concepts. Then, once we've designed our first concept, we get together and we combine the three different concepts using and. So here in this example, I have a nice big set of references to do with our smoking cessation. I have another nice big pool of references that are purely about RCTs in any topic. And then I have a nice pool of references to do with people with schizophrenia. And what we're interested in is the intersection of these three types of papers. So where this small little yellow triangle is, it's the combination of RCTs, looking at people with schizophrenia, and tools for smoking cessation. So how do we go about building this search strategy? Well, when we go into the databases, we do this one concept at a time. So first of all, I would go into, this is an example from Medline. I would go into the database. First of all, I would look for its subject headings. And for smoking cessation, there are several of those. So there's a mesh heading for smoking cessation. There's another one for tobacco use cessation. I'm going to use text word searches. So here I'm looking in the title and abstract for my nicotine patches. And again, lots of papers that are going to be talking about smoking cessation interventions or tools will probably use the words smoking cessation and stopping or quitting. So again, I'm going to use a phrase search here. Oh, I beg your pardon. This is on auto to help me find what I'm looking for. So what I've done here is I've built up my search in Medline. So we have our first set, our first concept, which is schizophrenia. So I've combined my Medline subject headings here along with my title search. And I've built up a nice big tool of nearly 170,000 articles just on schizophrenia. Then I build up my second search concept and I'm looking for smoking cessation tools. So again, a combination of subject headings, text word searches, phrase searches. Again, I'm interested in nicotine patches. It could be a nicotine patch, could be nicotine patches. So I've used my truncation symbol, my little star here, to help me find papers on that. And again, I'm thinking there might be terms like e-cigarettes or vapes or vaping. I'm going to combine all of my smoking cessation interventions in another big data set, line number 12. And again, I've got nearly 45,000 papers just on smoking cessation tools in any population type. Then finally, I'm interested in looking at randomized controlled trials. Now, the Cochrane Library has developed what's called a search filter. And what a search filter is it's a pre-made search strategy that has a selection of text word searches, subject headings, publication types that have been validated, which means they've been tested to find randomized controlled trials. Now, this is a very sensitive one, and these are the terms you use. If you do tend to do a lot of literature searching, I would recommend actually keeping it as a saved search. So instead of typing it out each time you want to run a search, you click save, and then each time you've got your RCT filter. So again, we have a combination of randomized controlled trial as publication type. We're looking for randomized in the abstract, in the placebo. This is a floating subheading. So again, combining all these words and tools. And another thing in the Cochrane RCT filter is they try and screen out animal studies as well. So that's what this line is at the bottom. So now I have my 3 search concepts in line 5, line 12, and line 23. And I'm going to combine all those using the Boolean operator and we can see from sort of nearly 17,000 schizophrenia papers and 45,000 smoking cessation papers, we are now down to roughly 300 papers, which are going to be papers looking at RCTs on smoking cessation tools in people with schizophrenia. So that's sort of how we go about in a very quick way of how we search for information. We use our PICO tool, we work out 3 to 4 search concepts that are of interest, and we design our search strategy around those concepts. However, when we are doing database searches, there's lots of limits on the database. And in a systematic review, we really tend to avoid using those limits. One of the things we prefer not to do, it's better to do by screening out your references, is to look at age groups. Again, there are age group tags in the database for adults and for children, and also for humans as well. The reason we don't use these is they're very, very accurate, but if a paper isn't tagged with this tool, then you're potentially going to miss it. Other limits that people quite often use are year of publication or English language. And I've also seen people using full text as well. Now, date limits and English language limits are shortcuts that you commonly see used. But really, if you want to reduce bias, it's not ideal. There are justifications for using year of publication. For example, if an intervention came in at a certain date, or there was a change of practice or a change of policy, in which case you can sort of justify in your paper why you would be putting in a year of publication. But in general, when you're searching, it's better not to do that. And it's the same as Judy was describing earlier. We don't necessarily want an English language limit because we're potentially introducing bias. One thing you should never do, particularly if you're doing a systematic review, is put in a full text limit for your papers. all that's doing when you put in a full text limit is searching for papers that have got free full text available on the web. Now, if you need to find some information quickly, that's fine, but for a systematic review, you're introducing a massive amount of bias by doing that. So you want to make sure that you go out and you find all the papers and you put aside some money for document supply. Okay, now we've talked about how when we're developing a search strategy, we've got to try and think about how is the author thinking, how will he express his information when he's writing a paper. And there's a lot to think about. It's an iterative process that takes time to build and to develop, but there are ways that can help you do this. One thing we find is you can recycle searches. So if there's a published systematic review on a topic that's quite similar to yours, it's perfectly acceptable to go and have a look at the words and terms they've used to sort of help you develop your search strategy. Recently, we were doing a systematic review looking at vitamin C, and there was a great Cochrane review that had lots of words and terms on vitamin C that we would never have thought of. I think particularly if you're not so familiar with the subject area, you're not necessarily going to think of all the alternative names, the chemical names. So if you can find a ready-made search strategy to help you out, that's a great shortcut for developing your search strategies. Earlier we spoke about the Cochrane RCT filters. There are plenty of those available. This link takes you to a great resource called Intertask, which is a group of information specialists, and they actually go together and collect and gather search filters and search resources. So on this web page, for example, if you're looking for prevalence studies or patient safety studies, lots of different methodology types. Lots of people have actually published systematic search strategies on different methodologies and different study types. However, you have to use them with care. When people have designed these search strategies, they've designed them for the particular question in mind, and sometimes it may not work so well with your search strategy depending on the concepts that you're using. So always sort of use them with caution. Check that it works, see if you have to modify and adapt it. The other thing you also need to do as well is if you do use parts of someone else's strategy, librarians and information specialists take a lot of time and care developing these strategies, so please acknowledge them as well. So that was a flying summary of how we build a search strategy. So when we're doing a systematic review, we want to make our searches as sensitive as possible. So we're using our Boolean operator OR. We're trying to think of all the alternatives of how an author will describe his paper, describe his population, what sort of synonyms are available, should we be using truncation, are there mesh headings available, make it as big and broad as possible. So what we're trying to do is create a nice big set and then narrow it down. It's an iterative process and it takes time. We take at least a week when we're designing a search strategy, and that's because we're constantly going back, we're looking at papers, we're teasing things apart. You design a strategy and then you pull up some references and papers and find certain terms that come up all the time, so then you go back and you add that to your search strategy. So if you are designing a search, always allow extra time than what you think. Each database has its own quirks as well. So symbols such as the truncation symbol can change between different database providers. You need to adapt and change the index terms because they're not always the same. So for example, Medline and Embase will not necessarily use the same index heading for the same topic. So you need to, every database you go to, you need to make sure that you have the correct subject headings. And if you have a librarian or an information in your institution, please go and talk to them and ask them for advice. Or if you've designed a search strategy, get them to peer review it. Judy and I do that all the time, and Judy is constantly finding typos in my search strategies. I sometimes find subject headings she hasn't thought of, or because I'm more familiar with an area, I might think of some terminology she may never have thought of. So it's really valuable to get someone else to have a look at your search strategy, because when you bounce ideas off each other, you make a far more sensitive, stronger strategy. And the other thing is it is always going to take longer than you think. Now, I'm going to ask Judy if she can launch a quick quiz for me. So Judy, I'm just going to...
Yeah, that's fine. I will
I'll unshare
Okay.
my screen. Stop share for a second.
That's okay. I mean, oh yeah, that's fine. So I'm going to go to our first question, which actually it's a question really to help us understand your experience really. So do you normally search PubMed or Ovid Medline or another Medline version of Medline? We've got for the people who are new, we thought we'd try some polls and questions in this session, so we can gauge a bit your experience, but also we can build on some of the content. So I've had a few responses, which is great. We're getting a few more in now, and we'll leave it running for another I don't know, probably about 5-10 seconds. I'll do a countdown, but yeah, which version of Medline do you normally use, or have you not really done any searching as yet? Okay, and just to let you know, if you can't see the poll questions, then please just answer in the chat and we can use that instead. Okay, let's do a countdown. So 5, 4, 3, 2, 1. Okay, so I've ended the polling, I've shared the results. So 72% of you are searching PubMed, 17% are searching Ovid Medline, and 22% haven't done any searching. So thank you for that. That's really helpful for us to know. And yeah, we've given you information about Ovid Medline and Medline. And actually at this point, I want to just point out that we've developed a Word document, a sheet, which has got lots of tips and tutorials for searching those different individual databases. So you get the technical knowledge of how you actually enter those terms and what you click. This presentation, we can just give you sort of an overview of the theory of how you do it, but you really need to practice those things. And logging on to some of the tutorials that we'll send out in this document of links will help. Okay, so I'll stop showing those results, and I'm going to now launch our next question. So this is, what do you do when you found too many records to screen? Should you limit those numbers by just looking at the last 10 years? And I think you can only select either yes, no, or not sure. This is a completely anonymous poll, and we don't know who's voting for what, so don't worry about it. And yeah, we've got some votes coming in now, so thank you. So should you limit your systematic review search to the last 10 years if it's looking very large? Okay, we'll just leave that running a little bit longer. And getting, yeah, over half of people have voted. Okay, so I'm going to do a countdown for the last 5 seconds now. So 5, 4, 3, 2, 1. Okay, can stop voting. So I'll share those results. So around about half of you thought that yes, you should reduce your numbers by just looking at the last 10 years. 30% said no, and 20% were not sure. So yeah, this is quite an interesting thing because we do get asked this a lot. This is a really common question, and really, ideally, you wouldn't limit your search to the last 10 years unless you have a really good reason for doing so, and that's not, the reason can't be because there's too many records. So, for example, if we're looking at smoking cessation interventions for schizophrenia, and we're looking at trials, you know, why would a trial from 1999 not be as good as a trial from the year 2000 if you cut off, say, for 2000 onwards? So you've got to have a reason other than it's just too big in order to put a date limit in. Okay, so that's our question. I'll go to the next question that we've got. Okay, so this is more about the actual search techniques that we use. Which of these two searches finds more records? Is it mint or chocolate? Or if we searched mint and chocolate? So which of those two searches would find the most records? And again, this is a very sort of common issue we have, where you're given those sort of two buttons on a database screen. Sometimes people make mistakes with this, either because they don't understand, or it's just a typo, it's just a silly mistake, but it makes a massive difference to your search results. Okay, we've got over half of you have voted. Thank you. We'll keep the votes open a little bit longer. Okay, so I'm going to do a 5-second countdown now for the last remaining votes. So 5, 4, 3, 2, 1, and I'll stop the polling. Great. Okay, so we've got, most people are saying mint or chocolate, but we do have sort of 33% of people saying mint and chocolate. So if we're searching for mint or chocolate, we are actually finding more results, because we're finding all the records that mention mint, plus we're finding all the records that mention chocolate. So we might find things that talk about mint sweets, mint tea, how to grow mint, all sorts of different records, anything to do with mint. And then we're also finding anything to do with chocolate. So we're finding strawberry chocolate, chocolate orange, mint chocolate, nutty chocolate, hot chocolate. So a huge variety of different things to do with chocolate, because we've said to the database we don't mind if the record mentions mint or chocolate, they're all going to be relevant. So that's why we're going to find more. If we search for mint and chocolate, we're telling the database to only give us the records which have the word in mint and also have the word chocolate within the same record. So that's where we're going to get things like chocolate mints, and mint flavoured chocolate, or a hot chocolate mint with mint in there. So there's obviously far fewer results for that kind of search. Okay, I'll stop sharing the results for that. Right, our next quiz we have, so actually I think that's for the following session, so let me just end that one for now, and we'll come back to that one. I've got carried away with running the quizzes. Okay.
Thanks for that, Judy. Sorry, I couldn't help out.
That's okay. Back to you.
Okay, back to me. So for this second part of the session, we're going to be looking at how we manage all the references we find when we do our systematic review. Can you see my screen? Have I?
No, not yet, Natalie.
Right, just bear with me for a second. Okay, oh, no, it's that one. Share. And can you see that now?
Yes, thank you.
Great. Okay, so we've designed a search strategy and we've found hundreds or potentially thousands of records for our systematic review. So what do we do to manage the results that we've found, and how do we report our search strategies accurately? So one of the things we use here at Leeds is reference management software. Because when we're doing a systematic review, we can find hundreds or thousands of references, and it's just too much to manage. So when we're using reference management software, it means we can put everything together in one place. So programs such as EndNote or Mendeley or Zotero are great. So we can automatically, they talk to Word. So when you're citing a reference and writing up your reports at the end, you can sort of create clear, accurate records in your referencing. You can create a personal library of your references as well. So again, you can put all your ideas together in one place, all the papers that are relevant. You can group by different themes. So sort of at a click of a button, you can pull up all of our papers on vaping. So you don't need to think which author talked about vaping. One article might be comparing vaping to nicotine patches. So if I have a group of references that are on vaping, a group of references that are on nicotine patches, that particular author, say it was right, I would be able to find them straight away. The other reason we use reference management software when doing systematic reviews as well is to remove duplicates. Judy spoke earlier about the need to look in multiple sources, to look in multiple databases to make sure that we're not missing out on any references. When you do this, you end up with hundreds of references that are actual duplicates. So the same journals get indexed in multiple databases. So as well as having unique content, there is also quite a large overlap between them all. So we need some way of actually finding out which are duplicate references and how we remove them. So we use EndNote at Leeds, and at a click of a button and we can remove them all. The other types of things you can do as well is once you've got a complete and clean record in something like EndNote, it's an electronic seamless transfer using a RIS file in between all sorts of different software packages that can do the donkey work for you when you're actually doing your review. So we're going to find our evidence in databases, so in say PubMed, the trials databases, Medline, Embase. We can create an electronic record, put it into our reference management program. We can use EndNote, Zotero, Mendeley. We sit there and we deduplicate all of those references, and then we want to do some screening. So quite a few people we know use EndNote to do their screening, but there's also, if you're doing an international collaboration or you've got multiple screeners, there's software available such as Covidence or Rayan, which we've been using on our AMIPS project, where we can do the screening together. So it doesn't matter where the researchers are located, you can all screen the same references together at the same time. Then once we've done our screening, there's other software we can use. RevMan and Covidence will also allow you to do data extraction. Quite often people will take the references out of Rayan and pop them into Excel, do their screening in Excel. And then finally, we need to sort of use our records and references again for writing up our reports at the end. So again, this is where we go back to our records in EndNote or in RevMan. Some of these are free and some of these are paid for, and there are so many software tools to help you with the systematic review process as well. I've got a link here to you to the systematic review toolbox. So here you can think about the approach you're using. So the tools I've just mentioned are the ones we use routinely. Oh, someone asking a question? No. But if you want to know what tools are available for different parts of the review process, I would strongly recommend going onto the review toolbox. And here they've got a combination of paid for tools and free tools. This slide is just a brief summary of some of the tools that you can use. We use EndNote, which is quite expensive, but it's really sophisticated, and once you've got it, you can use it for so many different things. There is a free version available online. It's not quite as good for deduplicating and some of the other things we use it for. But you've also got Mendeley and Zotero as well if your budget doesn't stretch to getting EndNote, but you just have to take a bit more time and it can take some patience. Again, screening, there's some paid for tools. Lots of our researchers love Covidence. But we've been using Rayan and that seems to work really, really well, which is free. Again, data extraction, Covidence is great because you can do your screening and your data extraction in the same tool. Or if you're doing a Cochrane style tool, there's RevMan is available, or most people have Excel if they possess Outlook. So technically I know it's not free. And then finally, when it comes to reporting, I would strongly recommend you use reference management software when you're writing up your reports, because you don't want to, if you need to change where a record is, if you need to change the order, it's a lot of legwork programs like EndNote, Zotero will automatically do things for you. So if you change the order of a reference, if you resubmit to a different journal and you have to use a different output style, a click of a button, the referencing is all changed. Okay, so we've briefly talked about how we manage all these thousands of references that we've got. But one of the key things when you're writing systematic review as well is how do we report what we've found and what we've been doing. It's good practice to be as clear, transparent, and reproducible as possible when you're doing a systematic review. If someone sees well-reported methods, then they're going to have a lot more confidence in the review itself and the reviewer that they know what they're doing. So some of the key things we think about reporting when we're writing up a systematic review is what is the full name and the coverage dates of the databases we're using. So for example, with Medline comes from multiple suppliers. So it could be from Web of Science, it could be from Ovid, you might be using the PubMed version. As well as that, you might be using coverage with records from, in Leeds we have from 1947 to present. We have another Medline database that starts from 1996. And then we have a third database that contains all the Medline records from 1947, plus all the records that haven't been indexed, plus a whole series of records that are non-indexed. So a lot of open access journals are not indexed. These are quite often the content that you see within PubMed itself. So it's a much bigger database, but because it's not indexed, it means we have to rely on our keyword terms to find all of our relevant papers. So if I'm using that database, if someone is reading my review, they need to know what database I was using and the dates covering. So if they replicate our search strategy and get different results, it helps point them in the right direction as to why it might be slightly different. Another thing you need to do as well is record your search strategies for every database you've used and every search. Depends on where you're reporting. You may not want to publish every single search strategy, but people will contact you if they want to find out more. So always keep a copy of your exact search strategy. It also helps if you find if someone says you've missed something, you can go back and see if it was something that went wrong in your strategy there. We also want to report methods where we've gone to find other studies. So if we've gone to the clinical trials databases, if we've, say, searched the World Bank, then what we need to do is we need to let our readers know what sources we've used, what terms we've used, the date we did it, because things get entered at different dates or they get taken out of databases. And one way we can sort of keep track of all sort of this flow of articles and papers and things we've done is through a Prisma flow diagram. And this will help a reader work out the number of references you found in all of your database searches, where the duplicates were removed and where things were removed from screening. So this is what our Prisma flow study chart looks like. So we can see at the top, these are all of our records. So we found 6,500 records from our database searching. And we also found another 34 records identified from other sources. As we flow down, after we removed all our duplicates, we were down to 4,000 records. Then we did our initial title abstract screen. This is where we lost records. We took 183 references through to full text screening. Again, it's really important to sort of document at this stage why they were removed from your final set of references. So again, we can use tools like EndNote to help us record the total number of records that we've found before our duplicates were removed. Other software that we'd use here is to look at the number of records after we've removed our duplicates. And then finally here, this would be where we'd be using software like Rayan or Covidence, where we're sort of recording all of our inclusion and exclusion decisions as we go along. There's tools that can help you create a Prisma flowchart. You don't need to do this from scratch. The Prisma Protocol website is a great place to start. Another thing I would strongly recommend as well is if you are doing a systematic review, read the actual paper that the Prisma statement is based on, because that actually itemizes all the different bits you're recording and why. I'll check that we've got it in our references, but if not, I'll put it in our list of resources that we're going to circulate after this. Now, when it comes to writing up our systematic review, we want to be as clear as possible. This example is from a recent Cochrane review, and here we can see which databases they searched, the dates that they searched them. So for example, they searched Central on the 6th of February in 2019 using the Ovid interface. They used the Medline Ovid version. Theirs is 1948. Again, they searched it on the 6th of February. They used Embase, DARE, CINAHL using the EBSCO platform, and the date range is from 1980 to present. ERIC, an educational database, and HealthStar Ovid. So when you are reporting your systematic review at the end, make sure you record every single database, the date you searched it, and the provider. Then we also want to report our other resources that we used. So we would talk about which trials registries we went to. So in this paper, they searched clinicaltrials.gov and the ICTRP registry. They also looked at the reference lists of included studies. So they looked at relevant systematic reviews to printed educational materials on professional practice. And then they went through the reference list, and all of the included studies in the reference list of the reviews, they actually added to their systematic review as well, and sort of scanned and screened those articles for their topic. Oops. Looks like they also did forward citation searching. So Web of Science and Google Scholar are both useful tools for this. So again, it's when you get a key reference and you look at what other articles have cited that reference, because quite often if it's citing a reference of interest, then it's about your topic too. Okay, one thing Judy and I do, and you can see this is a very old template, is we write everything down. We record every search we do. We save every search strategy. And the reason you do this is it's amazing how quickly you forget. You run your searches, you do your systematic review, and it can be months to sometimes years before you finally get around to publishing. Remembering exactly what you did that far behind it's virtually impossible. Another thing we like to do when we do that, as well as recording the dates we searched, is what search concepts did we use. Sometimes in different databases you may need to drop a search concept, or you might need to add one. So for example, if I was doing a multidisciplinary topic, say community engagement, I probably wouldn't bother putting health if I was searching the health databases, because I know most of the articles would be about that. But if I go into a multidisciplinary database like Web of Science or Scopus, to try and reduce the number of hits that I'm getting, I might add an additional concept for health and mental well-being, just to sort of reduce the number of articles rather than finding things about policing or education. So again, record the concepts you used in each different database, whether or not you applied any limits. This is really important. How many hits you got as well. For example, in Medline, sometimes you get twice as many hits in December as you do any other time of the year, because that's when they update all their records. So again, if you rerun the search a little bit later and the numbers aren't sort of slightly larger or sequential, it can sort of help you tease apart what's been happening. Judy and I also quite like to write notes as well to sort of help us with any hints and tips we've found, or if something was a little bit unusual, or if we needed to add something. And all of this helps when it comes to writing up your reports at the end. Okay, I think I flew through that. So I'm hoping I'll have lots of questions, because I did that far too quickly. I'm going to release the screen again and ask Judy if she can run another poll for people. Just bear with me for a second. And stop share.
Thank you, Natalie. Okay, let's try the next poll then. Okay, let me just continue. So here's our next poll question. How can I change my search to find more records that may be relevant? Okay, I think this is the wrong question. I'm just looking at the question and the answers. It doesn't quite look right to me. So I'm sorry, I'm going to end this poll and just see what the next question is. Okay, yeah, this is better. So yeah, this is the right question. So when we're reporting the search in a review, which of these do we include? So when we're writing it up at the end of the review, do we include the name of the database, the internet browser, the date of the search, the coverage dates of the database? So if you could, we've had a few already, but if you could start to answer those questions in the quiz, we'll give you 30 seconds or so to make those decisions, and then we'll share the results and maybe discuss it a little bit further if needs be. Okay, so about half, just over half of the people have voted. I'll keep it going a few more seconds. Okay, so I'm going to do a countdown for the last 5 seconds now. So get your questions answered. So let's go 5, 4, 3, 2, 1. Okay. So I'll share those results. So the question is, when reporting the search in the review, which of these do you include? So 100% everybody said name of database, which is great. That is definitely something we have to put in. Small number of you voted for the internet browser. This isn't actually something that you have to put in, and it wouldn't really affect the search in that it doesn't really matter. It doesn't matter which internet browser you would use for doing a search. It doesn't affect the results. So your search would be reproducible whether you did it in you access a website through Chrome or through Internet Explorer or Firefox. So we don't need that, but we do need the next two. So date of search, 78 of you voted for that, and we need that. And the coverage dates of the database, that was a bit lower, about 52% of you voted for that. So this is the bit in when you're describing the database name and it says Medline 1946 to present or Medline 1996 to present. And it's a really common thing which is missed off. I do some editing for a systematic review journal, and at least probably half of the time when I'm sending articles back, this is something I'm asking people to do, is the PRISMA checklist that we're trying to adhere to, the PRISMA guidelines, states that you should have those coverage dates in. So because my version of Medline may be very different to somebody else's version of Medline on their institution, they'll have different coverage dates. So in order to make it reproducible, we need to know what those dates are. Okay, that's great. I'm going to stop sharing those results. So we have come to the end of the slides and the quizzes, but we are around. This webinar was kind of scheduled. We had it scheduled from 9 till 12. I'm sorry if there's been some misunderstanding about the timings for this. So we are around for the next sort of half an hour. We've got some time to answer any more questions that you have. So if you could put any questions that you have for us in the chat, we'll have a look at those and answer them over the next sort of 10 minutes or so. So we'll just wait a little bit for that to come through. Okay.
Can't see anything yet.
No. That's fine. So just to, while you may be thinking or typing up some questions, couple of things to mention. So we're recording this, and we can make that recording, fingers crossed that's worked okay, we can make that recording available and also those slides available. They will go on the SharePoint place, which is where all the materials are for these webinars, and the the staff on AMIPS and response teams can access that, but I'm aware that there's other participants outside of those teams who won't be able to access that. If you're not in AMIPS and response and would like these slides or the recording, please can you send either me or Anna, who's also in this meeting I think at the moment, your email, and we can make sure that comes through to you. So you can send me that in the chat or privately in the chat if you like, and it's Anna Cronin de Chavet, who's the other person who will be sort of collecting email addresses as well. So that's one thing. The other thing is, as we've mentioned a couple of times, we've devised a list of sort of further guides for you, because this is a very practical skill and you really need to have a go and play with the databases, and follow some guidance as you're searching. So there are some online tutorials, workbooks, videos, things like that that you can use to help you do that searching, and we're going to send that to you separately. And again, if you want that sent to you, please give us your email address, or Anna's actually put her email into the chat, so you can just email her directly as well. Okay. Tolib's given us a nice comment. Thank you very much for that, Tolib. Yeah, we try to make it as practical as possible when we're doing things online. Okay. We still haven't had any particular questions about the searching or the databases or the reporting. So if you have any, pop that in. I'll just mention that this is the third webinar, and a fourth one is coming along. So Tony's next will be delivering the next webinar, and that's going to be about selecting studies, data extraction, those sort of next steps. So once you've done the search, how you process those and how you decide which studies make it in or not. Okay, we've got a lot of emails of people who want further information, so that's great. It's nice that you would like this. If we haven't got any questions, then we can sort of wind this down. And thank you for listening. Have you anything that you'd like to say, Natalie? And at this point, if Tolib or Tony have anything they want to say, please jump in.
No, I'd just like to thank everyone for listening. Again, apologies to lots of people who I noticed were coming in halfway through the second half of the talk. I'm not sure whether it was a time zone thing or whether the wrong information went out, but all of these will be available online, and we'll send out some resources as well with the link. Talib?
I think he may not be with us right at this minute.
Okay, yep.
So, he's unmuted.
No, sorry, I was on 2.5 calls in the meantime.
Oh, sorry, you just kept flashing.
No, nothing to add, but just a word of thanks to brilliant Judy and brilliant Natalie. Excellent session. Love the interactive format, and thanks for everybody's participation. It looks great, and no questions in my experience means either everything was perfectly clear or everything has been very unclear, and I'm 100% confident that we're in the first category. So I'm just credit to you both. Thank you.
Okay, well, thank you, Tolib. Okay, so I'm happy to sort of to close this. Oh, hang on, there is a question that I've just spotted here that's come through from Anna. Or maybe it's a comment. It's useful to both to know how to do the searches yourself, as you don't always have the funding for information specialists, etc. But also to try and cost them in or cost us in. Yeah, I mean, in your institutions, some librarians may be able to do some work for free for you. They might be, even if it's just to give you some advice. So it's always worth getting in touch to see what support they can give you. This is, for us, this is a really interesting thing. We love searching and we want to do this sort of thing. So we're very keen for people to get in touch as a profession. Tony's asked to make a comment as well. So yes, please, Tony, let's go ahead.
Thanks a lot, Judy and Natalie. This is a great presentation. Really practical and useful, particularly to those coming from low and middle income countries. And as I kept on saying, this is one of the practical aspects of systematic review people can really take away, because regardless if you're doing systematic review or even a primary study, this is very important. Yeah, just a comment that I want to make. Based on my experience over here, and when we started doing systematic reviews, we found out that most of the search aggregator engines that we use for that Ovid for Medline and other for Embase, the M3 for Embase, most developing low and middle income countries don't have it. The University of Ghana has a big library. It's one of the really well-resourced in Africa, but it doesn't. So we were doing a systematic review around hypertension. And then we got to know that we couldn't do the search from Ghana because we're going to rely on only PubMed, which is available over here, not not Medline. And you know that PubMed doesn't understand the medical, sometimes the medical language as much as you would have the Medline. So I want to, because this one is particularly relevant to those coming from low and middle income countries, how can we tailor this one to meet the needs of those people who want to do systematic review, not consulting somebody from from developed country, but maybe want to do it themselves? That is the question, what I have. And then the last one, because I'm probably not going to get opportunity to talk again. I see this one is really practical and very useful. So instead of me doing the next one, screening and selecting studies, I probably will talk it behind after we've closed this webinar. Why can't we now come and do something like managing the search output using the particular reference management system? Like, how do you work through maybe EndNote? How do you create your the responses and all those, and maybe RAM? That will really be helpful. I'm speaking for them because most of them haven't gone through this process before and they don't know what to expect. Can that really work for you? Can you, and Judy and Natalie, can you think about developing something practical, hands-on, showing people this is PubMed? When you go, this is how you're going to do it. And then when you finish, you can upload your listening to maybe EndNote, and this is how you duplicate. And after that, this is how you to the final state. Will that help? And could you also do something for us?
Yeah, okay. So yeah, we'll have a discussion offline about that. But we are this term about to do some EndNote training and things like that online for our own students here. Okay. So yeah, this is all kind of quite new to us, doing this over the screen, remotely. We normally do this in PC rooms, in IT suites, where you're right next to the person, and it's in that way it's nice in that you can point at somebody's screen and you can really see how everybody's trying to do it at the same time. So this sort of style of teaching is obviously quite different, and we're trying to figure out the best way to do that. I'm sure we can put something together. It's really one thing would be to kind of canvass if EndNote is the best tool for us to use, if that's what most of the people watching would be using, or whether we'd be better looking at a different free tool like Mendeley or Zotero. Yeah. Excuse me. So that there may be, we can discuss afterwards, but hopefully there's something. Okay. It might be a short session.
That would be helpful. Yeah. I think, I didn't preempt Tolib and Augustine about this, but I think after this we can sit down, draw something up and see what will meet the needs of our people, the participants. I think this is one of the areas. So thank you, Judy and Natalie.
Okay.
Thanks, Tony.
And kind of going back to your earlier point about the problem with not being able to search certain databases like Embase or things, or not having a very sophisticated search function for those databases. So you might have access to them, but you're not actually able to do the mesh searches or the M-tree searches, or do the sophisticated searches which we've been fortunate to do here in Leeds. I don't really have a good answer to that, to be honest. I mean, PubMed has the same data as Medline, but it's much harder to do the sophisticated search. I suppose if you're looking for trials, you would also use the Cochrane Library, and you could feel quite comforted in that Cochrane Library should have the vast majority of trials from Embase in there. So there are other databases that cover some of the Embase content, and Cochrane Library I would think would be the main one. There may be, yeah, I'm not sure. I think you might have to go more down the grey literature route of looking in maybe some of the preprint archives or the repositories, because it could be that people have put their journals in their articles in there first in these open access repositories, and then later on they might have managed to get them published in a journal which has ended up in Embase. So I think it's having a broader possible spread of where you're searching as many different databases in some cases, just to help you improve your chances of finding those papers, because even if they happen to be in Embase, you might not find it through your particular search, but you might find the same paper through a search of PubMed or through a search of the Cochrane Library, or even a Google search. So, and actually I was just thinking we haven't mentioned Google searching at all.
No,
that might be a
should
nice
add
thing,
that in.
Yeah, it might be a nice thing to sort of finish up on. We don't recommend, or it's not recommended to do Google searches, or well, to base your systematic review on a Google search, because we can't reproduce Google searches. When I do a search for smoking and schizophrenia here on my machine in Northwest Leeds, I will get different results to Natalie, who's searching for it in Northeast Leeds, and very different results to Tony, who may search for it in Ghana. Google is tailoring your results depending on which country you're coming from and which place, and also your search history, how you've done searches in the past. And it's trying to give you results based on some marketing preferences as well. So everybody gets slightly different results when they search Google. So even if I tell you very clearly how I've searched it, you can't reproduce that. So that's one major problem with Google and systematic reviews. And the other one is we can't actually look at all the results which Google send us. So they may send us hundreds, thousands, even millions of results. And it's just impractical to try and look through all of those. And I think Google will only actually show you the first 1,000 or 2,000 anyway. It doesn't let you download after that. So we can't be very clear as to exactly which ones we have seen. The best thing it can be useful for, though, is as a supplementary search at the very end of your review or the end of your searching. It is acceptable now, especially to help find grey literature, to do a Google search, to be very clear about what you're searching. So you need to list all the search terms you put into Google, but also be very clear about what you've actually looked at. So have you looked at the first 100 records, or the first 200, or the first 50? So if you give that sort of information, it's a lot more transparent about what you've done. And it may throw up a few new studies that you're not aware of. Okay, I think, yeah, we haven't had any more questions. We've had Tony and Todd make some final comments, so that's really helpful, thank you. And it's nearly 20 past 11 where we are in Britain. So I'm going to thank you all for attending. It's been great to have such a good attendance. Thank you all for taking part in our quizzes, in our polls, and in the chat. It's been really good to try that out and to see that it seems to be working quite well. And for sending in your emails. We'll be in touch with our further guides and yeah, the presentations. Okay, thanks everybody, and goodbye.
Thank you.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you. Goodbye.
Thank you. Goodbye.
Thank you. Goodbye.
Thank you.